Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
You know, it's wild to think about. You can have a multi-million-dollar robotic suite, right?
Oh, absolutely.
You've got advanced 3D imaging, these incredibly complex mechanical staplers that can fire multiple rows of titanium in just a fraction of a second. But when you really strip it down to the absolute foundation of surgical success, the literal thing holding the entire procedure together is just a piece of string.
Yeah, just a piece of string, the suture.
Right. I mean, surgical technology is advancing at lightning speed, but that foundational choice of what thread you use and, why you use it is still the ultimate make or break decision for patient outcomes.
It really is the great equalizer in the operating room. I mean, you can execute the most flawless, bloodless technical dissection, but if you choose the wrong material to put that tissue back together, well, the biology is going to rebel.
And then you're dealing with a mess.
Exactly. You're looking at dehiscence, you're looking at surgical site infections, or just a compromised functional outcome. The material has to respect the biology.
So, to all the practicing surgeons and doctors tuning in today, welcome to a custom deep dive tailored specifically for you.
Glad to be here.
Our mission today is to step back from the muscle memory of the OR. You know, that automatic reflex of just asking the scrub tech for a 3-0 Vicryl without thinking. We really want to extract the why behind pragmatic, procedure-oriented suture choices.
It's so important to revisit the fundamentals.
It really is. But before we jump into the physics and chemistry of it all, I do need to drop a quick note. This content is for reference only, and you should always follow local guidelines in your clinical practice.
Right, absolutely. So to give us a roadmap for this analysis, we really need to view every closure through 3 core pillars, because every single time you reach for a needle driver, you are essentially answering 3 biological and physical questions.
Okay, let's hear them.
Pillar number 1, are we using absorbable or non-absorbable material? Pillar number 2, what physical architecture do we need? So monofilament or braided? And pillar number 3, what is the specific tensile strength and duration required for the exact tissue you are handling?
Let's pull apart that first trade-off, because before we even get into specific polymers, it's really all about time and tissue healing mechanics, right?
Precisely.
The golden rule seems to be that the tissue's own biology dictates the timeline. We are constantly trying to match the degradation of the thread with the recovery of the tissue.
That is the biological imperative. You use absorbables where long-term foreign material is a liability, and crucially, where the tissue naturally regains its own native strength relatively quickly.
Right, so things like mucosa.
Exactly. Mucosa, the GI tract, the bladder, subcutaneous fat. These structures heal robustly. So the suture really only needs to provide a temporary bridge. Non-absorbables, on the other hand, are for tissues that need prolonged or even permanent scaffolding because they never quite get back to 100% of their uninjured strength, or just because the mechanical stress they endure is way too high to risk a failure.
Right. When you think about fascia in high-risk patients or a vascular anastomosis or fixing a hernia mesh, you're dealing with immense shear forces or pulsatile pressure.
Right.
If you need it to hold the line forever, you really don't want water molecules slowly breaking down your knot over time.
No, you definitely don't.
But that brings up the physical architecture of the thread itself. I mean, you can pick the perfect absorption timeline, but if the physical structure of the suture turns into a bacterial highway, the timeline doesn't even matter.
Yeah, that's the monofilament versus braided divide. It is the classic surgical compromise.
Let's get into that.
So a monofilament is a single extruded solid strand. From an infection control standpoint, it's fantastic. There are no microscopic crevices. It glides through delicate structures with minimal tissue drag.
But the handling is tough.
It's very tough. The trade-off is absolutely the handling.
Yeah.
Monofilaments have high memory. They want to spring back to their original straight shape, making knot security a real challenge.
Right.
Braided sutures, being interwoven multiple strands, well, they're the exact opposite. They are supple, they handle beautifully, they tie down smoothly, and those knots stay exactly where you put them.
But the cost of that beautiful handling is capillarity. I actually always think of a braided suture like a wick in an old kerosene lamp.
Oh, that's a great analogy.
Right, because that wick is designed to physically draw fluid upward. A braided suture basically does the exact same thing in a wound bed. It has all these microscopic spaces between the woven fibers that draw interstitial fluid and, by extension, bacteria deep into the tissue.
And that wick effect is disastrous on a cellular level because a macrophage, the white blood cell your body uses to hunt down bacteria, it's physically too large to fit into those microscopic interstices of the braid.
Wow, really? So it can't even get in there?
Exactly. But a staph bacterium fits perfectly. So the braid effectively becomes an impenetrable fortress for bacteria. They can multiply safely inside the thread, while the immune system is literally locked out.
That's terrifying.
It is. Contrast that with a monofilament.
Right. A monofilament is basically thick fishing line.
Pretty much.
It's slick, it's solid, bugs can't hide inside it, but it is notoriously stubborn. You have to throw, 5 or 6 precise knots just to make sure it doesn't spontaneously unravel.
Yeah, at least. Which is why you have to be so calculated about where you bury braided material. If you have a contaminated field, say a perforated bowel, you do not want a braided suture sitting in that infection soup if you can avoid it.
Makes total sense.
Which naturally transitions us to the toolkit designed to do its job and then literally vanish. The absorbables.
Let's start with the absolute workhorse of general surgery. Polygalactin 910, obviously famously known as Vicryl.
The classic.
This is a braided synthetic absorbable, but what's really important is the mechanism of how it disappears. We aren't relying on the body to mount an inflammatory attack to digest it, right?
Correct. Synthetics like Vicryl degrade via hydrolysis. The water molecules in the patient's tissue fluid naturally penetrate the thread and cleave the polymer chains.
So it's not an immune response.
No, it is a predictable, steady chemical breakdown, which is very unlike older natural sutures like catgut, which relied on unpredictable enzymatic destruction by white blood cells.
And the predictable timeline is why it's so ubiquitous. At 2 weeks, standard Vicryl drops to about 60 to 70% of its original tensile strength. By 8 to 12 weeks, the hydrolysis is complete and it's essentially gone.
Exactly.
That makes it incredibly versatile. You see it used for oversewing staple lines in the stomach or bowel, ligating mesenteric vessels, and parenchymal suturing and liver hemostasis. It's also the go-to for closing subcutaneous fat to eliminate dead space.
And it dominates urology and gynecology as well. You'll see a 3-0 Vicryl used routinely for bladder closure or vaginal mucosa.
Because of the handling.
Exactly, because the braided handling gives you that excellent knot security in tight, wet spaces, and those specific tissues heal fast enough that the 2-week strength drop-off aligns perfectly with the biological repair.
But again, going back to our kerosene wick analogy, you have to be vigilant. If you're dealing with an abscess or heavy fecal contamination, burying that braided Vicryl is just asking for a persistent site infection.
You're begging for it, really.
So what if you need an absorbable, but you absolutely cannot afford the wick effect? I assume you moved to polyglycapron 25. Monocryl.
Yes, monocryl gives you the chemical absorbability, but in a slick monofilament structure. The key difference here, though, is the extremely rapid loss of strength.
How rapid are we talking?
Well, at just 1 week, 50 to 60% of its strength is gone. By 3 to 4 weeks, the tensile strength is virtually zero.
Wow. So you are absolutely not using this to hold an abdominal wall together under tension?
Never. I mean, if a patient coughs violently on post-op day 4, a monocryl fascial closure would likely fail completely. Where monocryl shines brilliantly is cosmetic skin closure. Think about subcuticular intradermal closures for clean elective wounds, a laparoscopic port site, a breast biopsy, an open hernia incision, usually a 3-EO or 4-ZO.
It glides through the deep dermis without dragging. And because it undergoes hydrolysis so quickly, it actively prevents that dreaded railroad tracking scarring, right?
Exactly.
It basically outpaces the late inflammatory phase of wound healing. It holds the skin edges just long enough to seal and then gets out of the way before the tissue starts getting angry at it.
That's the perfect way to phrase it.
But what if we need the exact opposite? What if we need a monofilament that lasts a long, long time? That brings us to the heavy lifter, right? Polydioxanone, or PDS.
PDS is a slow-absorbing synthetic monofilament. It retains massive strength at 4 to 6 weeks, and it takes an agonizingly slow 6 months to completely undergo hydrolysis.
6 months is a long time.
It is, but this is your absolute go-to for high-risk, high-tension closures. The classic textbook example is a midline laparotomy closure. You're generally using a heavy number 1 PDS in a continuous mass closure technique.
Right, especially if that patient is compromised. If they are obese, malnourished, chronically on steroids, or if it's an emergency trauma laparotomy, their healing is going to be severely delayed.
Right. They need the extra time.
You need that thread to act as a steel cable for over a month. And it's also crucial in high-risk GI anastomosis, right? Like a hand-sewn pancreatic duct mucosa anastomosis using a tiny 50 PDS.
Absolutely.
But wait, I have to play devil's advocate here.
Okay, go for it.
Let's look at the logic. If PDS is a monofilament, meaning it inherently resists infection,
Right.
and it holds its strength for over a month for maximum safety,
Yeah.
and it eventually dissolves completely so you aren't leaving permanent plastic in the patient. Why isn't this the universal suture? Why are we ever bothering with Vicryl or monocryl?
It is a totally valid question, but it hits the wall of tactile reality in the operating room. PDS is a nightmare to handle compared to Vicryl.
Oh, really?
Oh, yeah.
Mm.
Because it is a thick, slow-degrading monofilament, it is incredibly stiff. It has a tremendous amount of memory. It just springs out of your hand. Throwing secure knots with PDS, especially in a deep, dark pelvic cavity, is technically frustrating and cumbersome.
So it's an ergonomic penalty?
An ergonomic penalty and a biological one.
Yeah.
Because matching the suture's degradation timeline to the tissue's healing speed isn't just a suggestion. It's a requirement for optimal healing.
I see.
You do not want a thick polymer sitting around for 6 months in vaginal mucosa that healed perfectly in 10 days. That prolonged presence of a foreign body causes unnecessary chronic localized inflammation, which can lead to granulomas or chronic pain.
Ah, that makes sense.
You want biological efficiency. Support the tissue only for exactly as long as necessary.
That makes perfect sense. The biology sets the clock. Which really brings us to the tissues where the clock never stops. Tissues that never regain full native strength, where you are forced to provide permanent scaffolding. We have to hold the line with the non-absorbable.
So sorry for the interruption, but this is important. We need your support to help us grow, reach more surgeons, and keep delivering cutting-edge surgical content. Press the support button and donate now if you like what we do. Let's get back to the podcast.
And the undisputed king of permanent support is polypropylene, proline.
Proline, right.
It is a synthetic monofilament, and biologically, it is practically invisible to the immune system. It causes incredibly low tissue reactivity and provides outstanding, indefinite tensile strength.
When you look at vascular anastomoses suturing a tiny peripheral vessel or a major aorta, you are almost always reaching for proline, usually in a 50 to 70 gauge.
Yep, almost always.
It's also foundational in hernia surgery for securing the synthetic mesh to the fascia. But that invisible smoothness is a double-edged sword when it comes to physics, isn't it?
The knots are treacherous. Because proline is so smooth and inert, a standard square knot can easily slide completely undone under tension. The friction coefficient is practically zero.
So you have to tie a bunch of knots.
Exactly. You have to throw multiple, meticulously squared knots, sometimes 6, 7, or 8 throws, just to ensure security.
Then we have nylon, commonly known as ethylon, another synthetic monofilament, but it handles a bit differently.
Right. Nylon actually does hydrolyze, but it happens so incredibly slowly, taking years, that it acts clinically as a non-absorbable.
Okay, so essentially permanent.
Basically.
Wow.
It has minimal tissue reaction, and it's extremely cost-effective. You will frequently see 3-0 to 5-0 nylon used for interrupted skin sutures on the trunk or extremities.
Right.
Particularly in contaminated trauma wounds, where you actively plan to monitor the site and remove the sutures manually a week later.
You also see large caliber nylon used as deep retention sutures in catastrophic abdominal closures, piercing the full thickness of the abdominal wall.
Very true.
But you have to be careful with permanent synthetics deep in the tissue. If nylon or proline gets colonized by bacteria months or years later, the body walls off that foreign material, creating a chronic sinus tract that will just constantly weep fluid until you physically go back in and surgically extract the infected suture.
Exactly. The body's immune system gives up on destroying the bacteria and just builds a fibrous tunnel around the whole mess to contain it to the surface.
It's just fascinating how the body reacts.
It is. Now, if you're in a situation where you need immense permanent strength, but you physically cannot manage the slippery knots of proline, you might reach for a braided non-absorbable, something like polyester or Ethibond.
You see polyester used for complex orthopedic ligamentous structures or really heavy-duty long-term fascial support. But again, you are explicitly trading the safety of a monofilament for the ergonomics of a braid.
Yes.
You are accepting that higher infection risk to get a knot that absolutely will not slip.
You are making a calculated gamble based on the anatomical need.
Which brings us to a material that is essentially a living paradox. Silk.
Ah, silk.
I have to say, looking at the clinical history, the irony of silk is staggering. Surgeons revere it. It handles like an absolute dream. It's supple, it doesn't have memory. The knots tie down perfectly flat and stay exactly where you put them.
Oh, it feels great in the hand.
But biologically, it's a disaster.
It really is the ultimate contradiction. The material that feels the most natural and ergonomic in the surgeon's hands is the one the patient's immune system perceives as a massive threat.
Why is that?
Well, silk is a natural braided protein. Because it's a foreign biological protein, it triggers a massive enzymatic macrophage response. The tissue becomes incredibly inflamed.
So despite how great it feels to tie a silk knot, its use in modern surgery has plummeted compared to synthetics. Today, you really only see 2-DOE or 3-DOE silk relegated to simple transient tasks.
Right, exactly.
Ligating a superficial omental vessel in an open case, or securing a chest tube or a Jackson Pratt drain to the skin. You actively avoid burying silk for deep long-term implantation because that biological cost, the intense inflammation and infection risk, wildly outweighs the ergonomic benefit.
The industry recognized this exact bottleneck.
Oh, they definitely did.
If throwing secure knots with inert, slick monofilaments is technically frustrating, but braided materials cause infection. What happens when you alter the fundamental physics of the thread itself?
What happens when you eliminate the knot entirely?
Exactly.
This is where surgical technology actually feels like sci-fi. Barbed sutures. Products like V-Lock or Stratafix. These are monofilaments available in both absorbable and non-absorbable polymers.
Right.
But during manufacturing, microscopic unidirectional or bidirectional barbs are laser cut directly into the thread. It's basically a surgical zip tie.
A zip tie is the perfect way to describe it. Mm-hmm.
The thread slides smoothly through the tissue in the direction of the needle, but the moment you pull back or let go, those tiny barbs bite into the surrounding tissue and lock the tension firmly in place.
They have completely revolutionized specific procedures, particularly intracorporeal suturing. When you are operating minimally invasively through a laparoscope or doing complex bariatric surgery like a gastrojejunostomy, trying to tie intricate knots inside a patient's body using long, rigid instruments is incredibly time-consuming and technically exhausting.
So with these, you can just run a continuous closure along the peritoneum or the posterior rectus sheath, and every single bite holds its own tension. You don't need an assistant to follow the suture and keep it tight.
It saves so much time.
But there is zero margin for error here, isn't there?
That is the vital clinical caution. While barbed sutures radically accelerate closure times, the surgeon must be incredibly meticulous about tension. Because the suture locks at every millimeter, you cannot easily back it out if you take a bad bite.
You're kind of committed.
You are. And, more critically, you have to be terrified of tissue strangulation.
Because the tension doesn't equalize along the line.
Exactly. If you pull a barbed suture too tight, it locks permanently.
Yeah.
You crush the microscopic capillary beds in the tissue edges. The tissue becomes ischemic, loses its blood supply, and breaks down, leading to a massive leak.
That sounds catastrophic.
It is. There's also the mechanical risk of the exposed barbs at the end of the suture line acting like Velcro. If a piece of small bowel brushes against an exposed barb, it can stick, potentially causing a devastating post-operative bowel obstruction.
So high efficiency, but you have to respect the physics.
Always.
All right, we've covered the hydrolysis and enzymatic chemistry of the materials, the timelines of absorption, and the mechanical physics of braids and barbs. Let's take all of this isolated theory and put it together.
I love this part.
Let's build a closure layer by layer in a high-stakes clinical scenario so we can really see how these decisions interact.
Let's contextualize it. Because the way you engineer the closure layer by layer directly dictates whether this patient goes home on day 5 or ends up back in the OR with a catastrophe.
Let's set the scene. Let's say we have an obese diabetic patient. We are closing after an open abdominal procedure with a major bowel resection. Let's start deep inside the GI tract anastomosis.
Okay, for a small bowel or colon anastomosis, we need a watertight seal, but we also need slow, steady support while the mucosa heals. So for an inner, full-thickness continuous layer, you are reaching for a 3 or PDS.
Right.
That monofilament minimizes tissue drag through the delicate bowel wall, and the slow absorption guarantees support for weeks.
And if you were employing a traditional two-layer closure, you need to reinforce that inner line. That outer ceremuscular layer often gets interrupted lumbar sutures. You might use a 3/0 Vicryl or even silk here to gently approximate the outer tissue without cutting through it, relying on the braided knot security.
Spot on. Okay, the bowel is secure. Now we move up to the major structural barrier, the abdominal wall, the midline fascia.
This is the ultimate high-tension zone.
This is where the physics are most extreme. When this obese patient wakes up from anesthesia and coughs violently, the lateral shear force on this fascial line is immense.
So what are we using?
You are using a heavy #1 PDS in a continuous mass closure. You need that thick, slow-absorbing monofilament to provide unrelenting mechanical support while the fascia takes months to fully fuse back together.
Now we are above the fascia, moving into the subcutaneous tissue. In an obese patient, you have a massive amount of dead space here. If you just leave it, it will fill with serum and blood, creating a massive seroma that is basically guaranteed to get infected.
Right, you have to obliterate that dead space. But the fat doesn't need permanent support, and it doesn't hold tension well anyway. So you switch your needle driver to a 2/0 or 3/0 Vicryl or monocryl.
Okay, so we're back to absorbables.
Yes. You take large bites of the fat to pull it together, closing the anatomical void. The suture does its job and then hydrolyzes relatively quickly, so you aren't leaving unnecessary foreign bodies under the skin.
Finally, we reach the surface, the skin layer. Now, if this was a clean, elective incision without bowel involvement, we'd want excellent cosmesis. We do a running subcuticular closure with a 3/0 or 4/0 monocryl.
Absolutely.
It glides perfectly through the dermis, holds the epithelial edges flush for a couple of weeks, and vanishes before it can cause that railroad track scarring.
But, and this is where clinical judgment overrides aesthetics, our scenario involves a bowel resection. The wound is inherently contaminated.
So the plan changes.
Completely. You absolutely abandon the buried subcuticular monocryl.
Yeah.
You switch to interrupted 3/0 nylon or Prolene sutures on the outside of the skin.
Because you were anticipating a problem.
Exactly. If a superficial surgical site infection begins to brew in that subcutaneous fat a week later,
Yeah.
you need an escape hatch.
Right.
With interrupted non-absorbables, you could easily snip 1 or 2 isolated sutures right over the erythema, let the purulent fluid drain out, and leave the rest of the incision intact. If you had used a running subcuticular stitch, you might have to unzip the entire wound.
Wow. That is such a vivid, pragmatic breakdown. You aren't just memorizing a preference card. You are literally tailoring the polymer chemistry, the physical thickness, and the microscopic architecture of the thread to the exact biological and mechanical demands of every single anatomical layer.
And that is the overarching reality we want to emphasize to you, the listener. Your choice of suture gauge and material isn't just hospital purchasing trivia.
It's life or death, essentially.
It is. Understanding the difference between hydrolysis and enzymatic degradation, or the physics of capillarity in a braided thread, directly translates to preventing fascial dehiscence, minimizing deep space infections, and ensuring durable, complication-free outcomes for your patients.
It all comes back to that literal thread, which leaves us with a really provocative final thought derived from the clinical texts.
Yeah, I love this point.
The material notes that while mechanical staplers are incredibly sophisticated and widely used, hand-sewn sutures remain absolutely crucial for complex defect closure and delicate anastomosis.
It raises a fascinating question about the ultimate limits of human engineering versus biology. I mean, will we ever invent the perfect synthetic suture?
Right, a material that handles with the supple ergonomic perfection and not security of natural silk, but possesses the biologically invisible infection-resistant properties of a Prolene monofilament.
Or will surgical closure fundamentally always remain an art of balancing biological compromises?
Definitely something to ponder the next time you're struggling to tie down that slippery Prolene knot in a deep pelvic cavity.
Absolutely.
Well, we hope this deep dive gave you a fresh mechanical perspective on the foundational tools in your hand. If you liked this content, please don't forget to share it with at least one of your colleagues or friends to help spread the word.
Yes, please do.
And make sure to check out our YouTube and other social media pages. Also, do check out our previous season and episodes. We cover some very relevant clinical topics you won't want to miss. Thanks for listening, and we'll catch you on the next one.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference.
And don't forget to share with us your advice, feedback, and the topics you would like us to include.